All right, everybody, good afternoon. Very nice to see you. I'm Dr. Gavin Dreyer. I'm a consultant nephrologist at Barts Health. I work at Whipps Cross. Thanks for joining this Pan Northeast London CKD webinar. This is maybe the third or fourth one we've done. They've been hugely successful. I really enjoy doing them. A personal thank you to Joanna North for getting us all together and organising everything so immaculately. Well done. It's a great pleasure to be here. We've got two fantastic talks. I would say that because I'm one of the speakers, but more importantly than me, the main event today is our brilliant senior dietitian, Tadala Kawale, who's going to talk to us about hyperkalemia and hypertension in CKD. I'll follow that with some information about the anemia of CKD, which is also a very popular topic. A little bit of housekeeping. We're recording. Please switch your mic off if you're not speaking. Cameras on would be always a great pleasure. If you want to ask us any questions, there'll be time for Q&A at the end of each of our two talks, then at the end of the discussion as well. We'll leave some time for that, but do drop questions in the chat and I will try to keep up with them. And then right at the end, Joanna's going to put some feedback in so we can learn what we did well, what we didn't do well, and particularly what you'd also like to see in future webinars. Before Tadala starts, I'm going to just give you a quick update on the service. Joe, if you wouldn't mind, could I share my slides if that's all right? And let me know, you should be able to see these full screen. Is that right, Joe?
Yeah, we can, yeah.
Fantastic. So let me just fill you in where we are with the virtual CKD service. The strikes, both junior and senior doctors, have been very challenging for all of us. And the service has generated a backlog, but I'm really pleased to see that's reducing. And we are making really good ground into the cases that have accumulated because of the strikes. On top of and beyond the Pan Northeast London webinars, we are running locality or sort of former CCG based CKD education on a regular basis, which will supplement the higher level topics that we are discussing here. So please do look out for those education sessions. We've done one, I believe, in each of the seven boroughs of Northeast London. And speaking of Northeast London, the virtual CKD service in EMIS is coming to Barking, Havering and Redbridge very soon. We've had lots of team meetings and we're really excited to see the rollout, hopefully in the next few months, but I'm quite guarded about when that will start because we've got to get all the technical aspects right, get all the governance processes in place. So we had a fantastic meeting yesterday. We're much further ahead than I thought we would be. So that's really good news. What changes are coming in response to the increasing workload and the challenges that have been brought about by the strikes? We are slightly changing how we deliver the service. We're going to be focusing on a weekly basis much more on the new referrals rather than the reassessments, although the reassessments are very important. We're also building and going to deliver to you all a sheet. I think it's about 8 frequently asked questions, the most commonly asked questions from primary care, to give you some starters and signposts before a referral is made. We've also done some really innovative work in City and Hackney, where we're doing practice level CKD registry reviews, looking at patients with CKD who are not coded, identifying why and implementing treatments. And that's been really positive. And we're going to evaluate our impact in early January, and we'll feed back to you about what that looks like. Some very important reminders for each and every one of you on the call as referrers into our virtual CKD service. Can we please ask that you ensure there's a very clear and discreet clinical question for the virtual CKD team? More often than not, referrals are coming in asking for management advice, which is not unreasonable, but equally doesn't really direct us to help you answer a specific clinical problem. So can I please ask you all to write down, either in the consultation or the letter that you send, a very clear clinical question. That doesn't make our lives easier. It makes us respond better and be more helpful to the referrals that are coming in. On top of and beyond that, it's also really important that there's a minimum data set in place for us to answer the management issues surrounding CKD. And I've written it down here: a urine ACR, user needs a blood pressure, and ideally a urine dipstick within 2 to 3 months of the time that you're making a referral. We often find that if the clinical information is out of that window of 2 to 3 months, one of the first things we'll say is it's very hard to give cogent or sensible advice until those measures are repeated. So please do bear that in mind. Often we would have given some advice before in a virtual CKD review, but a similar question is asked usually by a different member of staff at the practice or a locum. So please do check back to see whether or not there's been a virtual CKD review, because often the question would have already been addressed. And please remind your patients they should never expect to either attend hospital, receive a phone call, or have a video contact with anybody from the kidney team. This is a discrete computer-based review of patients' notes. My last slide before we hand over to Tadala, I think, is this, and I'm going to quickly jump windows. I'll put these web links in the chat because there's some fantastic resources to start diagnosing and managing CKD before referrals are made. We've talked before in this forum about the kidney failure risk equation, which is the new NICE approved guideline for referral to a nephrologist if the 5-year risk is greater than 5%. That used to be stage or GFR based, but that's changed. And my colleagues Kieran McCafferty and Linda Tarm have done some amazing work building incredible resources for the management and coding of patients with CKD, which is a lot of the work we do in virtual CKD. And I am just going to jump out and very quickly, if I can actually manage to do this, share what this looks like. So I'm here on the kidney failure risk equation, not yet built into EMIS, but it will be. Click on the kidney failure risk equation button, put in the relevant clinical detail, a 45-year-old male with a GFR of 30 and a urine ACR of 200. And you can do this on an individual patient basis, has a very high risk of dialysis or transplant requiring kidney failure at both 2 years and 5 years. And this is a new risk stratification tool, which is NICE approved. Moving on to the website, the London Kidney Network website has got a huge array of resources for identifying CKD, treating it in the context of type 2 diabetes or without, coding on CKD, interpreting results. As an example, this is Kieran's 3 within 3 actions to save lives about testing for albuminuria, measuring for diabetes, and looking at heart failure. And it gives 3 clear actions in 3 months about ACE inhibitors, SGLT2 inhibitors, and blood pressure control, with very, very sensible, pragmatic, highly useful step-by-step steps to take in primary care. So I will copy in those links into the chat. But without further ado, can I please introduce Tadala Kawale? Did I say so right? Tadala Kolawale, I beg your pardon, Tadala, who is a very senior and experienced dietitian working with me and many others at Barts in the London as a dietitian, and is going to talk to us about hyperkalemia and hypertension, and then we'll have some time for questions. Tadala, thanks very much.
Thank you very much, Gavin. My name's Tadala, as Gavin said. Thank you for sharing my slides, Joanna. Okay, so my name's Tadala, as I said, and I'm one of the renal dietitians at the Royal London Hospital, and I do cover the VCKD clinic with regards to any referrals that are made to the dietetics department. And if there's anything that I can say that I've learned from that, is a lot of my patients tell me or ask me, why didn't I know about this sooner, or what can I do in order to make the changes that I need to. So I hear this from the VCKD, or I hear it when they enter our low clearance service as well. So our patients are very keen to understand and to know what sort of things that they can do with their diet. And I do understand the time pressures that you have. So today what I wanted to do was just to give you a little bit of information as to what you would be able to say, or what the research is saying at the moment with regards to potassium and hypertension, especially for our patients with CKD. If we can move on to the next slide, please. So I'm going to be talking about like the general dietetic input that I'd have at each stage. So as the dietitians, we would see the patients right from when we see them in VCKD, or whether they've got nephrotic syndrome, all the way with stage 1, right the way to when they've had a transplant and when that is failing. And then also we would see them if they're going through supportive care, dialysis. We're with the patient all through the way, which is really nice because you get to build some really strong and good relationships. Then I'm also going to be talking about potassium and hypertension, obviously metabolic acidosis, because that will have an impact on the potassium levels as well. And then I'll also be talking about understanding the potential renal acid load, which will have an impact on metabolic acidosis later on. So we'll look at that. There are quite a few things that we will look at, and I am mindful of time, so I'll try and be quick and answer any questions later on. If we can move on to the next slide. So as I said, from the dietetic intervention, so mainly what I'm doing in stage 1 and 3, if a patient is referred to me at this point, my goal is to preserve kidney function for as long as possible. That's for me to look at any conditions that they have, try and preserve kidney function. So if they've got diabetes, high blood pressure, obesity, it's managing all these things and trying to help reduce this so that we can slow down the progression of the condition. So that's what I'm doing mainly with your patients. And then obviously on dialysis, it's some symptom control and then nutrition support or whatever needs to be done. And then likewise with transplant and supportive care. So from a potassium point of view, I generally do not restrict potassium levels between stages 1 and 3 unless I have been asked to by the doctors, or if we feel that there is a high potassium level there and we need to make a change to the diet. But in general, I don't find that I have to do much restriction at that stage. With my stage 4s and 5s, there is a lot of information that needs to be done or given to these patients. But a lot of the time, what I've found is if you tell a patient, don't eat a banana, for some reason it interprets in their mind that you're saying don't have any fruit and vegetables. And so patients often struggle with this. And I hear a lot of the time, especially when we're talking to them about diabetes, the main complaint is, oh, the two diets contradict each other. One says eat vegetables and the other one says do not. And that's not what is actually the case. So we'll go through a little bit of that a little bit later. And then, of course, we've got the dialysis, some potassium on dialysis, and there's a lot of things that go into that. We will be talking to the patients and everything. So if we go on to the next slide, please. So what do we actually recommend for patients that you'll be seeing in the community and in primary care? What do we recommend? So we'd recommend the DASH diet, we recommend the Mediterranean diet, and a low-carb diet for those patients that have got diabetes. Now, all of this, I know, is where the contradiction comes, where people say, well, then that's obviously going to make their potassium go up. And there is a worry because all of these are quite high in potassium, especially the Mediterranean diet. I mean, you've got a lot of potassium that these patients will be having, especially because there's very little animal protein in there. But what we're finding, or what research is showing, if we move on to the next slide, is that it's very dependent on the bioavailability of potassium in the foods that our patients are eating. So if patients are having more of a plant-based diet, then the phytates or the oxalates and all these things are going to be reducing the bioavailability of the potassium for the patient. So we find that some of the potassium is excreted and some of it is lost. So we are then looking and seeing, is there actually a very strong association between what our patients are actually eating and what the potassium concentration is? And what we've seen is that there is a weak association, but there is still work that needs to be done. So it's not to say it is completely safe to have large amounts of potassium, depending on blood results. No, we're not saying that. But what we're saying is there is a weak association at the moment, and we are not telling our patients to completely avoid potassium or reduce it drastically when we know that they've got chronic kidney disease or when they've got hypertension, because we know that there are adverse effects of following a low potassium diet. There's constipation, which will then cause the patient to have high potassium because of the constipation. And so we're looking at all of these things and trying to think to ourselves, where can we strike a balance? What does the research say? So if we move on to the next slide, we will see, oh, that's very small, sorry about that. But it's just a list of the trials that have gone on. And I think potassium is a really tricky one, and people are struggling with that because it's very hard to have really robust research in the area, because there's so many contributing factors that can affect the potassium levels for patients. And then also finding out what is it exactly that people are substituting. Is it supplementary potassium, or is it potassium that's coming purely from the diet? And it's very hard to do that, even with food frequency questionnaires or with very close monitoring from a dietitian. Is still quite difficult. So more research is required in that area. But in general, what a lot of the research is telling us is that if you have the potassium intake, a higher potassium intake, you will generally find that you will reduce or slow down the rate of the annual eGFR decline. And that is ultimately what we want to do for our patients. And so we're focusing mainly on increasing the potassium content by encouraging the DASH diet, by encouraging a Mediterranean diet, even just saying to patients to have a general healthy, balanced diet. Now, one thing that I have found with my patients, again, is that when you link the diet and the changes that they need to make to their condition, you're going to get a better outcome, because it's clear, we all know eat your 5 fruit and vegetables a day, but how many of us even on the call actually achieve the 5 fruit and vegetables in a day? And so we found that patients generally would do 1 patient out of 3 patients would achieve that. And so if we help the patients to understand the why is it that you need to increase your fruit and vegetables? Why is it that you need to be having a healthy, balanced diet? We're likely to get them to do what it is that we want them to do, or to promote the behavior change that we want to see. So if we move on to the next slide, please. Now, a lot of the time we're worried about potassium and hypertension, and we're thinking if we increase the potassium, then there is going to be the adverse effects of having high potassium. A lot of the time, you see a high potassium, straight away, everyone is saying, cut out this, cut out that, don't eat this, don't eat that. Straight, everybody blames it on the diet. But there's so many other factors that are non-dietary causes that we should look at first before we look at the diet. So looking first, as I mentioned, acidosis, metabolic acidosis, that's the area that I want to focus on today. So if we move on to the next slide, when we're talking about metabolic acidosis, why are we concerned? Now, we know that this can cause the shift in anions and cations, and that causes an increase in potassium, serum potassium. So we then notice this, and then we're then worried about cardiac events. We're then also knowing that when the acidosis is high, this can lead to progression of kidney disease, which is a cycle, because acidosis will lead to kidney disease progression, which then will also lead to increased and higher rates of acidosis. So at the moment, we see majority of metabolic acidosis happening in patients with CKD stage 4, but research is showing that if we can produce or introduce a better diet at stage 3, we're likely to see a slower decline in kidney function and also less of the metabolic acidosis later on. So we'll talk through about what things that I tell my patients to have in order to reduce the acidosis or to slow things down. We know that if there is acidosis, there's increased endocrine disorders like insulin resistance, which then is not good for our diabetes patients. And then we also know about muscle loss and bone loss as well. So these are all things that we're looking at and concerned about, especially for our patients where this is a chronic condition. We want to be making sure that we can keep them as healthy as we can for as long. Okay, on to the next slide. So when we're looking at metabolic acidosis from a diet perspective, so in general, what we do is we know that patients will have a certain type of diet. Now, a long time ago, historically, this is what we were eating. We had a diet that was very vegetable based. It was low in sodium, high in fiber, high in potassium, and the acid load was about -88. Nowadays, we are way above that in the positive, so between 50 and 100. And why is that? And that's because we're eating more animal protein, we're eating more sodium, there's less fiber in the diet. And so these are the areas that we need to be focusing on when we're speaking specifically to our patients and reminding them. These are things that I will be telling my patients to make sure that they're reducing the amount of high production acid foods that they would be eating. So if we move on to the next slide, I'll be able to identify and to show you which foods these are. So generally, from a dietary perspective, I'm looking at this from an individualized approach. I would look at your blood results, see what your blood results are saying, see whether or not I'm looking after you because of nutrition support. Do I need to make restrictions at this stage? What is it that I am going to be looking at? What is my focus with you? I'm looking at your macronutrients. How much energy is your diet providing? Are you symptomatic? Where's your protein sources coming from? And when I look at all of these things, I can decide and look to see how much with acid producing foods you are having. And this is what we then call the potential renal acid load, which is what we'll be looking at. So metabolism of food. So most proteins, so your meat, your eggs, your fish, your grains, those will produce acid. And although I'm not promoting an alkaline diet, I am not promoting an alkaline diet, but most of the fruit and vegetables that we would be telling our patients to have will produce that alkaline effect. And that is what we want in order to neutralize that those acid levels, or that regulation that's not happening very well with the kidney function decline. Milk, fats, and sugars are classed as neutral, which is oftentimes beneficial for our patients, we'll find. And I think with regards to the milks, it's probably because of the calcium content inside of that. Now, another thing that we would be doing is encouraging our patients to obviously have their sodium bicarbonate if they're on this medication. But before we get to the point of them needing the sodium bicarbonate, making sure that their diet is wholesome, making sure that they are following these healthy advice that we are giving them. This will then help to make sure that these patients are on the right track. So if we move on to the next slide, please. So looking at the dietary impact, I thought this is quite a nice diagram. So you can see here, vegetables, obviously giving that more of an alkaline effect. And then interestingly enough, your fish is more acidic, but it's the animal protein that I just want to look at. That's obviously going to be giving more of the red. So if we're trying to promote a healthy diet as well as trying to be more green with regards to the environment, we are going to be encouraging our patients to have some plant-based meals and to reduce some of their animal protein. Now, if they do reduce their animal protein, that will also reduce some of the potassium that they're having. So a lot of people are very worried and saying, oh, well, if I go onto a plant-based diet, is that not going to be more potassium? We forget that if you're substituting your animal protein with plant-based, remembering the bioavailability of the potassium in the plants anyway, you are going to be having less potassium than you would have if you were having an animal or animal protein based meal. So it's just reminding our patients to say that it is okay, and also reminding clinicians, because I think a lot of the fear comes from us projecting onto our patients. And so just for you to be comfortable and confident in giving your patients the advice to have the plant-based diet. Now, I know I saw a comment pop up about patients asking for diet sheets. So there are some diet sheets that I'd be very happy to share with you. Kidney Care UK as well are very, very happy to share their diet sheets. Everything is online. It also translates into several different languages, so you can click on that and then it can take you to a language that you would like, and you can choose the language. It can read it out for you. So it's a very inclusive website. So I definitely would encourage you to direct your patients to that, because patients as well tend to find that they find their information online and it's not very good information that they're finding. I do again understand that you only have a limited time with your patients, but these are life-changing things that they're having to think about and go away, and they're just going online and getting whatever information that they can get, because I do understand that community dietitians are also very nervous of seeing renal patients. So I do understand the pressure and the position that you're in. So if we move on to the next. Another thing as well that we've realized is that a challenge that we have, obviously, one of the first things when patients are diagnosed with high blood pressure, one of the first things that we tell them is reduce the amount of salt. Again, salt also increases acidosis, so it's very important that we bring this down as soon as we possibly can. Now, you can see I've put some pictures here of processed foods, but if we're telling our patients to have 5 grams of salt in a day, it's very easy to reach that level, especially if they're having processed meals. So if we can move on to the next slide. Okay, so in summary, what I would be telling my patients is encourage your patients to follow a healthy diet, link it to chronic kidney disease so that they know that, okay, if I make this change, this is going to happen. If I do this, this is helping my kidney. Patients oftentimes come to me and tell me, I didn't even know that there was something wrong with my kidney. I've had blood tests and I was told, yeah, there's something wrong, but it's okay, and I've been put on medication. Encourage some meat-free meals for your patients. So encourage them to try having the plant-based meals. Now, I know in the community that we have, especially in Tower Hamlets, we have a lot of patients that are already on a plant-based diet, but it's educating them on the general healthy diet of regards to reducing our overall fat content that they're having and looking at the cooking methods in which they're using to cook those foods. So again, stressing the importance of whole grains and fiber-rich foods with regards to making sure that patients are not constipated. If you are concerned about potassium, then focus on reducing, as I said, those processed foods or animal proteins, and trying to increase more of these vegetables and fruit. Now, remember, not all fruit and vegetables are alkaline, but it is good to bring those in because there are other added benefits of having the fruit and vegetables, things like your gut health, also very important, bowel movement. So it's really important that we bring these things in. Being mindful of additives. So nowadays we do have a lot of potassium additives in our drinks. We have potassium additives in crisps. So it's things like that. I remember speaking to the stoma nurse and telling them, because they were telling patients to have Wotsits when they were having overactive stomas because of the sodium content. But now Wotsits have changed from using sodium to actually using potassium chloride. So having to just make sure that everybody is aware and being mindful that there are potassium additives in a lot of the food, and these are more bioavailable. So trying to run away from these, or trying to get your patients to have as much fresh food as possible so they're not having access to these additives. Directing your patients to reputable sources of information. I've got some links on the slides which I believe will be sent out to everybody. And then being mindful of financial implications. So if somebody's having food from a food bank. This is where I would be thinking, I need to be mindful about what information I'm giving them. I'm not going to be telling them, yes, you need to be having berries and all of these, because I know from a food bank, you are not going to necessarily get berries. So my information has got to be tailored to what that patient is having. And then again, promoting our low salt diet. And then if we move on to the next slide, I think that's the last of them. Okay, so these are the useful links that I was saying that you can get from Kidney Care UK. So a lot of information. Kidney Care UK also do a recipe book that you're able to request and order for free. So you can tell your patients and direct them to that. So if anybody's feeling worried or concerned about what things that they should be having, that's something that they can look into. All right, thank you very much.
Tadala, that's brilliant. Thank you. Colleagues, whilst you're thinking about questions, comments, or any challenges for Tadala, Shahid has got a couple of questions here about, you're right, every time I'm asked to change my lifestyle, it doesn't last 24 hours, Shahid, it lasts 24 minutes. Tadala, what practical hints and tips do you say to your patients about the sustainability of the changes that we would all advocate for them? How could they do that?
I always say involve the whole family. If you're trying to make changes by yourself, it's going to be difficult to cook two separate meals. So involve the whole family so that everybody's doing it. With little things like exercise, it's not running a marathon every few minutes. I mean, what is that saying that they now say? Sitting is the new smoking. So stand up as much as you can. Do movement. Don't sit down throughout the whole day. Do some exercise. That will help with your blood pressure. It will help with your diabetes as well. It's little small changes, even just having an extra piece of fruit every day. That's all you need to think about. Add a little bit of fruit. So I don't tell patients to move from 0 to 500 in one day. No, we take it on a step-by-step process, and I do regular reviews with my patient, and they do have my contact number if they need to contact me for anything. So it's a step-by-step thing. Allow your taste buds to change. Salt is a big thing in our community. I think I realized when we did some research, there was a Inyoni research paper, and we found that some of our Bengali patients were actually having about 10 grams of salt in 2 meals, and that's quite a lot of salt for them to be having. And if you're trying to undo that, you can't say go to 1 gram, go to a no added salt diet. It's impossible, and that's unrealistic. So if we get them to reduce gradually and allow them the time for their taste buds to change, because over time your taste buds do change in about 4 to 6 weeks. So you just need to give yourself the time. And like I said, it's just pushing with the patient. This is your why. Your why is really important for anything, whether you're doing business or whether you're changing your life, understanding your why. And that's what I really try and push with my patients as much as possible.
Thank you. Right, colleagues, any other questions for Tadala? Some resources there. I've put in the chat also something from Kidney Care UK. Any other questions? I've got a couple whilst our colleagues are thinking about them, Tadala. How often should we monitor potassium in some of the early stages of CKD, CKD 3 and 4? And particularly, how soon after you suggest a lifestyle change or a diet change to your patient should you come back and re-measure the potassium?
Well, I actually just give the information and hope that they will start to make the changes straight away, and then that should decrease. Patients do oftentimes have another blood test, so I will check on to see at their next appointment when they come to see me if they've had a blood test before then. Most of the time, like for the VCKD patients, I may not see that patient again. I may not see their bloods again, but like I said, they do have my contact details when I send them. Potassium changes should change quite soon, within 24 to 48 hours, with regards to how you do your diet. So it should reduce if you reduce what you're eating. So I do find that with my patients, just like with our dialysis patients, when we do check their potassium and then we check it again when they come in, it does change within a few hours, 48 hours. So I wouldn't say I have a recommendation, but I would make sure that it is frequent. So when you are checking like your iron levels, I believe that you would be checking your iron levels. For some of your patients, you will be checking every 6 months. For some other patients, you're seeing other things that you're checking for every 3 months. So when you're doing those blood tests, it's just checking that those are routinely on there. And then also, if you find that you do have a higher potassium, looking at the bicarb level as well, because oftentimes that's neglected in the community. So looking to see what the bicarb levels are to see the level of acidosis for our patients. And then that way I know whether I need to be very strict with the patient with regards to the diet, or if we can implement other things in order to help with that.
There's a huge mix of community groups from different cultural backgrounds, different ethnic backgrounds. I think the Kidney Care UK website has got quite a lot of resource to tailor dietary advice based on culture, isn't it, and lifestyle. Is that right?
Yes, it does. I mean, we're working on trying to make sure that our dietary recipes that we have are multicultural. So we're always looking for people to give in some recipe ideas. So if any of you've got any recipe ideas, please feel free to send them through to me so that we can put them on for our patients online. So it's just trying to learn together and just accepting it as much as we possibly.
Great. I think this might be the last point we take now on hyperkalemia. Shahid's come and says, what about pointers for labelling of salt? I guess you mean on food, Shahid, is that right? The sort of, you could buy a salad or a sandwich and it's got, red, yellow or green, different amounts of salt. What would you say about that, Tadala? Because the labelling, I agree, is really confusing.
It is really confusing, but I always tell my patients to look at the back of the label and look at the 100 grams. So when you're looking at the 100 grams, don't look at the proportions, but look at the 100 grams. And there's certain levels that I would say. So we've got 0 to 1.5, which would be classed as green. And then you've got your 1.5 and above. No, sorry, 0 to 0.3, and then 0.3 to 1.5. And then anything above 1.5 would be something that I'd be telling my patients to try and avoid. So I do give them a leaflet. They do have access to that. It's also on those diet sheets that you would get when we see a patient and we send out anything on salt. So they do have information on that. And then they also have information on what foods or what pairings with which spices to pair their foods with in order to enhance the flavor and not rely solely on salt. So we do provide that for our patients. It is confusing when you're looking at sodium and then some places say salt, and then when there's a mix between potassium chloride and sodium chloride, there is a lot of the mix there, and I do understand that, but that's all in the diet sheet and it's also in the books because it's very difficult to just explain and hope patients remember. I always try and give them something that they can take away and look at later on once they've calmed down a little bit.
Dala, thank you. That was really, really definitive and very, very helpful. Stick around because I'm going to talk for about sort of maybe 15 minutes about anemia. We'll have 5 minutes at the end if there's any more questions. I'm going to quickly share my slides. And if anybody does have another question for Tadala, it's perfectly fine to drop it in the chat. We'll come to it in just a second. Colleagues, right now, I hope you can see my slides. Shout if you can't. I'm going to talk you through anemia and CKD, which is another hot topic and generates lots of referrals to the virtual CKD service. I want to give thanks to too many people here. The reason I've listed all my sources of information is because it's very hard to define a definitive guideline for anemia in CKD. I guess the NICE guidance is probably what we're all going to use, but it's not wonderfully user-friendly. So I've drawn this here from my own personal experience, UK Kidney Association, international guidelines, and up to date. Let's see how we get on. A quick reminder about the pathophysiology of anemia. It's multifactorial. The total number of circulating red blood cells in CKD is reduced because of microvascular trauma, often due to diabetes. There's a degree of slow chronic GI blood loss, which doesn't necessarily mean everybody needs a top and tail endoscopy, but is often due to angiodysplasia or the ever so slightly higher incidence of peptic ulcer disease in CKD. And red cells, which normally have a lifespan of 100 to 120 days, have a lifespan of 30 to 40 days in the uremic environment of CKD. And all this leads to decreases in hemoglobin, decreased oxygen availability, reduced levels of hemoglobin because of the reduced amount of erythropoietin, because damaged, scarred and fibrosed kidneys do not produce enough erythropoietin. And a lot of what I'm going to tell you about today is about replacing iron and replacing erythropoietin, because ultimately, if the EPO levels are too low to stimulate sufficient red blood cells, you're going to get anemic patients. Here's some headlines. Quite difficult to define the anemia of CKD. The WHO guidelines for anemia differ between men and women, 130 grams per litre in men, less than 120 in women. NICE says it is prudent to investigate for anemia in CKD when the hemoglobin falls below 110. And you'll see in a minute that the target for correction of hemoglobin is actually, upper limit should be 120, which is less than where you would normally define anemia in men. And I found this a little bit confusing. What I would say is that anemia directly and, if you like, exclusively due to CKD is uncommon before at least CKD stage G3B, which is equating to an eGFR of 45 mils per minute. And I've put here that other causes of a low hemoglobin should always be considered both above this GFR value of 45 mils per minute, but also below it. it is quite tricky to sometimes work out how much of an anemic picture is being contributed to by chronic kidney disease, and it is always worthwhile screening for red flags and doing a bit of anemia workup irrespective of what the GFR is. But that figure I have in my head of 45 mils per minute means it's uncommon, but not impossible before that level of GFR. It is common in general. Here's a survey of 15,000 people in America, and they tried to identify the prevalence of anemia in patients with CKD. And you can see at a GFR of 60 mils per minute, very few people were anemic, 9% with a GFR of 30 mils per minute, and between a third and 2/3 of patients with a GFR of 15 mils per minute were anemic. This does not necessarily mean that the anemia was exclusively due to CKD. This is rather a story about the prevalence of CKD per GFR cutoff, and you can see the impact of worsening kidney function on the prevalence of anemia. So why treat patients with anemia? Well, it's been shown to improve the quality of life, to slow the progression of CKD, and to dramatically reduce adverse cardiovascular outcomes. With a hemoglobin of less than 100, the incidence of left ventricular hypertrophy and cardiovascular events goes up. And interestingly, and I'll explain a bit more about this later, with a hemoglobin above that target of 120, the cardiovascular outcomes are also worse. So we are not trying to normalize the hemoglobin to traditional or normal levels because the cardiovascular risk goes up as well. I've talked about quality of life, and it's very hard to dissociate anemia from tiredness. Tiredness and fatigue, probably the number one symptom of patients with chronic kidney disease and those who are receiving dialysis. And sadly, there's no guarantee that replacing the iron or giving an EPO is a hard guarantee that fatigue or tiredness will improve. There are certainly anecdotal cases where that is the case, and some of my patients do better and feel better with a higher hemoglobin, but there often is not a very good correlation between the absolute level of hemoglobin and the absolute level of tiredness and fatigue. But there are other very compelling reasons why treating anemia is important, particularly because remember that cardiovascular disease is the number one cause of death in patients with CKD, and reducing one of those factors, as in the anemia, is hugely important. Here are a few caveats to be aware of. If you're looking after patients, as we all do, who've got stable, mild CKD, I don't know, GFR 40 to 50 for several years, if the GFR is stable, it is very unlikely to be the cause of a new progressive anemia. It can be quite tempting to ascribe the anemia itself or the progression of the anemia just to the CKD, but that's not the case. If the CKD is stable, then a new or progressive anemia would not necessarily be expected. The anemia of CKD, the anemia of chronic disease, of any chronic disease, normally has a normal MCV. And I would argue that there's a red flag if outside that range, particularly microcytic. And I think in a microcytic picture, that really needs investigation of the GI tract. In a macrocytic picture, thinking about things like B12, folate, thyroid function, alcohol, and all the other components we look at. So the MCV is fairly key here. I mentioned also that this target range, and this varies depending on what you read. Some people say the target range is between 100 to 115. Other groups will say the lower value should be 105 and the upper value should be 120. So I've put here a fairly broad figure of a target range of hemoglobin for treating CKD and anemia between 100 to 120 grams per litre. I mentioned before that under that value, left ventricular hypertrophy is common and serious. Above that value, two fairly old studies now, CREATE and QUIRE, and some that have come since, have identified the cardiovascular risk goes up as the hemoglobin goes up. I wonder whether that's to do with the microcirculation and microvascular disease. It is tempting, as I mentioned before, with fatigue and tiredness to try to sort of push the hemoglobins a little bit higher, but the evidence is that can actually incur a higher cardiovascular risk. So when should you test patients with CKD to see if they are anemic or to see what the situation with their anemia is? I think it's rare to have a set of U's and E's done without having a hemoglobin done. Certainly in our secondary care practice, very happy to hear differently in primary care, but essentially up to date and nice. I recommend if your GFR is greater than 45 mils per minute, you should be checking the hemoglobin at least once per year. Very vague here. If the GFR, beg your pardon, is less than 45 mils per minute, check the hemoglobin twice a year. Now, I don't think that argument holds if you've got a patient with a GFR of, I don't know, 15 or 20, where the anemia is more likely to be common. They may well be on treatment with intravenous iron and erythropoietin, where more frequent monitoring of the hemoglobin is going to be sensible and necessary. So those are fairly broad strokes, but I guess need to be contextualized to the patient in front of you. Now, if someone is anemic with CKD, I put a very vague phrase here, and it's deliberately vague. Work up as you would normally, because I cannot find a convincing set of investigations that should be done exclusively in the context of CKD. So it is fair and proportionate to evaluate the patient in front of you and consider what investigations, including but not limited to investigations of the GI tract, should be done. I'm certainly not going to sit here and say that every patient with CKD and anemia needs to have an endoscopy, but it needs to be on your radar. And if there are red flag symptoms, GI symptoms, low MCV, that certainly becomes much more important. And I'm not going to sit here and preach to the excellent GPs of North East London how to investigate and work up anemia in general. My approach when I'm seeing anemic patients, either in virtual CKD or in my clinic, is to be guided by the history and the examination. I have a relatively low threshold for investigating anemia, as I suspect that most of us do, but I'm not going to sit here and mandate and say, well, we won't treat anemia unless and until they've had a colonoscopy and an OGD. I'm not entirely sure that that is right for each and every patient in front of us, but we need to take an individualized risk management approach. What I would say is, on top of and beyond the routine, or if you like, usual tests we would do for anemia, the two tests that we rely on the most in our virtual CKD clinic in general nephrology, albeit dialysis, transplant, peritoneal dialysis, are the transferrin saturation, or the TSATs, and the ferritin. Our guidelines on prescribing intravenous iron or starting patients on erythropoietin and adjusting those doses really rely on those two key tests, the transferrin saturation and the ferritin, much more so than the iron levels or the total iron binding capacity. And that's pretty much globally where you'll find the nephrology community relying on transferrin saturation, which is the available iron, or erythropoiesis, and ferritin, which is the storage version of iron. Now, I have varying experiences of the availability of the transferrin saturation as a test that is routinely done in primary care. And I'm very happy to hear if there's differential experiences across the patch. I think it's fairly straightforward to get a ferritin. But if you are concerned that you're seeing a patient with CKD and they are anemic, I would argue that above and beyond the routine or normal tests you would do, please do check the transferrin saturation and the ferritin, because if you're referring to me because you're worried about the anemia or want my advice about what to do with the anemia, I will find it challenging to deliver that advice without these two tests. It is possible, but this is the best way of assessing the iron stores and guiding our therapy. Right, treating and monitoring anemia and CKD. So based on those tests, I mentioned transferrin saturation and the ferritin. If their TSATs are less than 20 and the ferritin less than 100, you've got a situation where iron replacement therapy is almost certainly going to be needed in the context of anemia. And the next slide says, if a patient's anemic with low iron stores and you feel that CKD is the likely cause, then it is perfectly reasonable in a primary care setting to start treating with an oral iron initially. And I am agnostic as to which one. I don't even have a personal favorite. You use them more than I do. If you prefer ferrous fumarate to ferrous sulfate, I can live with that. They are differentially impactful. They have differential levels of available iron in them. I personally am not going to sit here to advocate for one oral iron preparation over another one. There's a deliberately vague statement here that oral iron is less effective as the eGFR reduces. That is true, but the question is there a GFR beyond which you should not give oral iron and only start with IV iron? I don't have a particularly hard or good figure in my head. I've been taught differently over the years. I think if the GFR is less than 20, then you might want to think about using an IV iron. But to be quite honest, if you've got a patient and they've got a GFR of 17 and they're taking a twice-a-day oral iron preparation and their hemoglobin is fine, as are their transferrin saturations and ferritin, I would be perfectly happy with that. It is often the case that we get referrals saying, like, I've tried oral iron, the GFR is a little bit low, and the hemoglobin is still low. I can't get the transferrin saturations and ferritin up. We would certainly say it's time to switch from oral iron onto intravenous iron, and there's more on that to come. So I'm afraid I've been purposely vague, and unfortunately the guidelines aren't wonderfully helpful. There is, I think, a broad consensus that checking the hemoglobin and iron stores every 3 months is appropriate. And that seems to be proportionate, and I think that is probably a target that we can achieve. We want to make sure that ferritin tends to keep under 500 nanograms per mil. Above that, then there's a risk of sort of chronic iron overload. So that's a figure that you'll see in most of the guidelines. Now, when might you need to refer for the anemia of CKD? And just come back to the last slide, I would say that if you've got a patient who's anemic, they've got CKD, you've tried oral iron, you've maximized the dose, and that has not improved the situation, as in the hemoglobin is not at the target range, there's no shift in the iron stores, it's time to refer to us in the virtual CKD service. if the anemia has been properly worked up and we're all comfortable that we've not found a cause that needs addressing above and beyond CKD, that's important because we're very unlikely to treat with IV iron or EPO if there's a potential source of anemia on top of CKD. So if there's a real thought that there's an issue with B12 or folate, or there's an issue with I don't know, iron absorption in sort of chronic GI disease, or there's an issue with microcytic blood loss, then it's quite difficult for us to treat with IV iron and EPO. And these are the patients who really need to be investigated. The pathway, I checked with we've got a dedicated renal anemia team. Chris and Colette, they're brilliant. They work at Myland Hospital. They deliver intravenous iron for CKD all the time. They will start, monitor, support you with erythropoietin dosing and treatments. I asked them whether they would accept direct referrals from primary care. The answer is no. And what they're asking is for you to refer those patients through to the virtual CKD service. We'll review, we'll assess them, we'll make sure it's time for IV iron and EPO, and then we will refer them on to the renal anemia team. That is our responsibility. And then that team will liaise with both the consultant nephrologist and also the primary care team. You'll get letters identifying when your patients have had IV iron, if or when they've been starting on an EPO, and how the dose will change. So the anemia team are really superb. I don't expect anybody in primary care to be starting or referring patients for IV iron for CKD, or to be starting or monitoring EPO. I believe that's really the job of the kidney team at Barts Health. Colleagues, a summary, before some questions and some chat, anemia is common. It's not always CKD related, and it's really important to be confident that the other causes have been appropriately investigated and ruled out. Treatment initially starts in primary care. Blood tests in primary care supported by the virtual CKD service. We'd love to hear about these patients. Anemia is a significant problem in terms of cardiovascular disease, and it's something that we can remedy, and it's something that we can make better, and it's something that will help us reduce the cardiovascular risk for our patients. Okay, I'm going to stop there. I'm going to stop sharing. I'm going to come back and have a very quick look. I've got to jump onto another call in 5 minutes, and I can see there are lots of questions. And there's one from Shahid about heart failure and cardiovascular disease and heart failure and CKD. Shahid, are you online? Do you want to just shout that one out?
Sorry, thanks, Gavin. Excellent talk, because this is one area that has been the subject of many of my advice and guidance requests. Yep. The problem I get is that I don't know. There's something coming from the heart failure guys that people should be incredibly replete with iron. You know, in the advanced stages of heart failure, and it just happens to be, you know, similar to all, you know, underneath the 45 EGFR. You know, all of the different concurrent conditions tend to merge. People tend to be on antiplatelets and anticoagulants as well, which complicates matters. So is that, would you say that the iron is probably more important than worrying about the actual HB per se? Is that the headline?
You know, I do a cardiorenal clinic, Shahid, and we're really obsessed about getting people intravenous iron in the context of heart failure. Not everybody with CKD has heart failure, and there have been some, I forget the study's name, a really impactful study looking at the value of intravenous iron in terms of heart failure symptoms and outcomes, which, to be honest, is a slightly separate and more niche issue here. The more people you make iron replete, the less erythropoietin you need. And in patients who are already on erythropoietin, you can reduce the dose of erythropoietin by boosting the iron levels. So I think that heart failure CKD question may be a little bit niche for this chat, but certainly it's absolutely vital. I agree wholeheartedly that the best iron is the one that the patient will take. And that's absolutely right.
Thank you.
There's a hand up from, let me see if I can find it, Dr. Gupta. Hello, Dr. Gupta.
Yep. Hi. Thank you. I mean, this is a very, as confusing it is, I think it's definitely a very good talk. Thank you for this. I'd put my question in the chat as well, and I thought I'd just explain it in a way that, you know, what you are actually saying is that we look at the ferritin levels, which are the iron stores, and try to maintain it over 100, because for us, between 30 and 100 is a normal ferritin. So are you saying, suggesting that if there is a ferritin iron stores in CKD patients where the ferritin is less than 100, we should be actually thinking of repleting this, even in the even in the presence of low hemoglobin?
Yeah, the ferritin level.
Or normal hemoglobin.
The way we interpret ferritin in CKD is completely different to how we interpret iron deficiency and anemia without CKD, and it's really confusing. So I want my patients to have a transferrin saturation greater than 20 and a ferritin greater than 200, which is far higher, I think, than you would normally expect or normally achieve. So yes, the target ferritin is higher, the target transferrin saturation is higher, and that feeds into the other question that's just come in here from Dr. Giles about why the iron is low. And it's multifactorial. You don't properly absorb iron, Tadala will tell us here, in CKD across the gut, and you tend to lose iron through a chronic slow GI leak in the gut. So the ferritin levels are persistently low and therefore need to be dramatically higher than you would normally expect. So it is perfectly reasonable to get the ferritin levels above 200, the transferrin levels above 20, and then re-look at the hemoglobin. And in instances where you've got the ferritin up, you've got the transferrin saturation up, that means they're relatively iron replete. If the hemoglobin is not coming up, it's time for erythropoietin.
So just one follow-on question from that. Again, the hemoglobin levels, we are expecting it to be over 120. And if they are not gone over 120 with everything that we have done with the oral iron therapy, because sometimes the anemia clinic will not actually take these patients for iron infusion. And sorry, from where we are at the moment, BHR, we don't have a budget.
No, I know that, not at all. So the target hemoglobin is between 100 and to 120. We don't really want the hemoglobins above 120 because that incurs a higher degree of cardiovascular risk. So again, the diagnosis of anemia and the treatment of anemia and the targets for anemia are confusingly, because we're nephrologists and this is what we do, they are confusingly different to the general population. Colleagues, I'm deeply embarrassed. I have to go on to another call with some patients. I do apologize. Thank you very much, each and every one of you, for coming. I'm Tadala, if you can hang around, that would be amazing. I can't be late for the patients. I'm so sorry. Please do fill in the feedback form. Thank you for your patience, and I'm really sorry I have to go at short notice. It's lovely to see you all. Please keep coming. There'll be another one in a couple of months. Come to the locality sessions. We'll send the slides round. Good afternoon, everyone.
Thank you.
Thank you, Gavin.
Thank you. If anyone's got any questions, I'm happy to answer them. Otherwise, I'm happy for us to end the call, Joanna.
Thank you, Tadala. Does anyone have any questions? I don't think so.
Can I just say, can you feedback to, I will do it to Gavin as well, but again, thank you very much for both of you. Can you thank Gavin? He's managed to actually forge a path through the minefield of anemia and CKD. Because to be honest, as I said, looking at all those guidelines and the alphabet soup, right, he made it very simple in about half a dozen slides. So thank you both.
Great, we'll let him know.
And can we have a copy of the slides as well, please? Can that be circulated if that's okay?
Yes, I will send them around to everybody. And you'll also get a link to the recording if you wanted to listen back as well.
Just as a feedback, I think this is a minefield, and some further, events on this topic would be extremely helpful. Thank you all. Thank you.
We'll feed that back. Thank you so much. I think our session 4 is going to be on the 30th of November, but I'll make sure that everybody gets the details of that to sign up if you're able to attend.
Thanks a lot.
Thank you. Bye.
Thank you so much, Tadala. Thank you. Thank you all for joining.